Not. So if you find any question, within your comfort zone, please feel free to take that on. Anyone would like to take that question? Okay.
Right.
Okay, so I'll take that again. Irregular menstruation from childhood.
Right.
And then women within the ages of 37 to 39 or early 50s who already have.
I think Dr. Olagunju did very, very, very good basic explanation of that from the very beginning. A girl child at the time of birth is born with all the follicles you're going to need for your entire life. So imagine a basket that has, a set number of balls in it. By the time one gets to puberty, which is the age at which your sexual reproductive functions and organs are better established, for a girl child, half of those follicles have gone atretic. That means they've dried up and gone away. So you have just that half left for the rest of the reproductive cycle. Now, at the time of puberty, your body's hormones are beginning to connect with each other to start the cyclical monthly bleeding pattern. Now, as with everything that is just beginning to start off, it takes a few twists and turns here and there before it becomes fully established. So for a girl child at the beginning of puberty, it is expected that for the first year or two, your cycles will be irregular because you have anovulatory cycles because your body is trying to figure out its pattern. So, the eggs are growing here, the lining is trying to proliferate there. So it is expected for the first year to two to have irregular cycles. You see a period this month, the next 2-3 months you may not see a period, and then after a while a pattern is established. However, if it goes beyond 1 to 2 years, please see your pediatric gynecologist or a general gynecologist so investigations can be done because there are other possibilities like PMOS that we've talked about. So to keep that in mind, but don't panic at the first cycle. If you've not seen your first menstruation by the age of 17 years, you need to be seeing your pediatrician because she talked about quite a number of congenital conditions that have happened. And she mentioned something very critical. Unlike the male, where if there's something wrong, you can almost cite it at birth. For a female child, it's harder. It's by the time they get to puberty and you're expecting some things and you're not seeing it. And so the mother, please pay attention. The father, please pay attention. So once these things start happening, you can take them to the gynecologist to see. There was something else you asked about, 35 years onward, is that menopause? More likely, yes, it is. Because back to the same analogy, you have a basket that you have a set number of balls. By the time you get to puberty, half of those balls have been taken out instinctively. Now, at every cycle, every month, one ball is taken away. It's a set number of balls. You're not allowed to refill the basket. So every month you take out a ball, every month you take out a ball. At some point, you have no balls left to help you continue on, and that's the hallmark of menopause. And we define menopause as 12 months of not seeing a period at all, then you're menopausal. One very important element to also be aware of, before you get to that final destination, there is a precursor, which we call the perimenopausal period. So you have a critical number of balls that you need to function maximally as a female. As you get below the critical number, you start having some symptoms that give you, and that is also established by irregular cycles. So the beginning of your reproductive life, irregular cycle. Towards the end of reproductive life, irregular cycles before you get to the final point of normal menstruation. So very likely, from 40 years onward, if your cycles have stopped being regular, then very likely menopause.
Interesting. We still staying on menopause, on menstruation rather. I want to drive the conversation towards the male counterparts a bit, but before we go there, there are complaints about serious menstrual cramps since childhood. And the question is, how can we deal with this? In addition, questions around heavy bleeding, right, up to beyond during menstruation of up to 8 days, especially after C-section. Is that normal?
Right. Okay. So painful periods. So we can have painful periods classified as primary and secondary. Primary painful periods are usually along when a woman just starts her menstruation. Primary means there's no cause that you can hold responsible for it, except the normal menstrual pattern. Of course, there are some dietary things that can impact some of the hormones that get released during menstruation. Your prostaglandins and cold sugar tends to affect it and makes menstruation painful. Now, the other important part is what we call secondary dysmenorrhea, which is painful periods that is as a result of something. the main culprits are usually fibroids or endometriosis. If your periods shouldn't be that painful that they become debilitating. And interestingly, accounts for 40% of women's absenteeism from school and from work. If you're having painful periods to that degree, please see your gynecologist so you can be evaluated so that treatment can be offered. Beyond the treatment of what is actually causing the pain, you can actually be given appropriate medications to handle the pain. The second question was about heavy menstrual bleeding. Now, the normal pattern that is expected for menstruation, yes, okay. The normal pattern for menstruation should be 2 to 7 days. If you're bleeding for more than 8 days, if you're bleeding for more than 7 days, it's not normal. Please see the doctor. If the volume of bleeding per day is beyond 80 mils, it's not so. If you're bleeding and you're seeing clump and clots of blood, that's not normal. And let's not normalize what is not normal. It's okay to see your doctor and get evaluated. After a cesarean section, if you're bleeding heavily, my recommendation is go back to see your doctor. You shouldn't be, and the pattern of bleeding after a C-section should be reducing with each day, and the color of the bleed should also change. So the first 2 days, you would expect some, heavy bleeding, but the bleeding should start changing in its volume and its color to light pinkish, and on until it totally disappears. So if you're still bleeding heavily after a cesarean section, please go get it checked out because something may be on the line that needs to get sorted earlier rather than later.
Thank you very much for that. So, please, you can book consultations outside and then let's start.
Sorry, it's very important to say that just make sure you're going to the right hospital. There are lots of gynecologists. I clearly can't see everybody, and the aim is not for everybody to, come to me. But I have on one hand, I can list like 20 off the top of my head, 20 fantastic gynecologists that you can go see. So in your locality, because the aim is also not for you to travel long distances, because that will then make people not going to see their doctor. Because if I have to travel from Ikoyi to Bagada to see my doctor, you won't keep up your appointments. You're going to fall through the cracks. So there's a gynecologist in every locality. Please find your gynecologist and then keep up with that. And family practitioners to family medicine consultants, they are trained and fully able to take care of our gynecological needs as well. I think is the other information I should put out there.
All right, thank you very much for that. You just spoke about hormones, and we know that hormones play a key role in ensuring that people get pregnant. How about low progesterone with women? Does it mean that they cannot get pregnant if progesterone is low? Also, can someone with high prolactin still become pregnant? What does elevated prolactin actually mean for fertility?
Dr. Alao, you want to pick that up?
Yeah.
All right. I would come in from the family medicine perspective so that it doesn't seem like she's answering all the questions.
Please.
Okay. For hormones are very necessary, for fertility, especially the reproductive hormones, the progesterone, estrogen, prolactin, all those things come into play. There has to be a balance, they create the right environment for pregnancy to happen. So just like she said during her presentation, there's no absolute, in science. Yes, it's very common that when the progesterone level is low, you need some certain level of these hormones to be present, not too much, not too low for pregnancy to happen. But when it is too low, or actually the prolactin you mentioned, when the prolactin is high, it's high tendency that pregnancy will not happen. High level of prolactin will prevent pregnancy. But there may have been some very occasional cases where, a woman could still get pregnant despite the high prolactin levels. So that's why I said there's really no absolute, but it's better to get a good balance of the hormones. So when there are imbalanced hormones, one should say the gynecologist or the endocrinologist. Yeah.
Okay, yes, it is. So if I was to just emphasize, low progesterone levels, it's a bit tricky because what does progesterone do in pregnancy? The role of progesterone is to support the pregnancy and to keep the uterus quiet for the entirety of the pregnancy until it's time for the woman to go into labor. It's not a heavy top liner for women who end up having miscarriages as a cause of the miscarriage. I know there's a lot of common conversation on that. They say I have low progesterone levels, so I need to take. It's like Dr. Laura said. It's not a heavy contributor. That's the word I'm looking for. It's not a heavy contributor in miscarriages or even preventing pregnancies. There are more likely, 20 other things that are responsible. And so I don't want everybody to focus on low progesterone levels. For prolactin, if your prolactin levels are high, what prolactin does is it inhibits the hormones that allow ovulation to occur. So if your prolactin levels are high, ovulation is likely inhibited. And you will see it in your symptoms. So you would realize you're probably not seeing a menstruation and you're having irregular periods. And so once that happens, then of course, go see your doctor, and then there are medications that can be prescribed.
All right. So still on hormones, let's just quickly address this as well. We had a specific question about combining cabergoline and aripiprazole. Now, I know this is a very specific question when treating high prolactin. Without necessarily, leveraging on this question to sort of answer for everyone who might be taking some sort of medication that would likely affect their hormones. What are the considerations that they need to make, actually, if they are looking to get pregnant?
I think that responsibility lies with the doctor, because there's something we call drug-to-drug interactions. And so what we would ask the individual to do is lay all your medications before the doctor, so the doctor can know how to manipulate your medications, avoiding drug-to-drug interactions. And what drug-to-drug interactions means that if you're on some certain type of drug, it can impact and affect the efficacy of another type of medication. So it's not something I can answer easily here and say, oh, use this or don't use this. It's just drug-to-drug interactions. Lay all your medications before your doctor, so your doctor can juggle your medications properly to help you achieve maximum benefit of your medicines.
All right. Final question on hormones, and I will direct this to Dr. Lau, since we started to talk on it already. There are questions around low sexual desire, vaginal dryness, lack of ovulation, and all of that. The question is, what's the relationship between their hormones and all of this, and what can be done about it?
So, low libido, that's a low sexual drive, vaginal dryness. The symptoms depend on low levels of estrogen, especially. If anyone is experiencing that, yes, needs to see the doctor, the gynecologist. Because this is pertaining to the woman now. For men who are experiencing low libido, may need to get their testosterone levels checked as well, because these are sex hormones that, help you feel something, When the levels are low, definitely tells that, showing these symptoms that the person is experiencing. So what to do is to, of course, get assessed by the doctor. Yeah.
All right, thank you very much. We talked earlier about male reproduction. We had addressed female reproduction, and had addressed the fact that women within the ages of, say, 31 upwards could experience menopause. What is the similitude of menopause in males, and at what age should we start to make considerations as it relates to that? Anyone who would like to take that question?
Let me just, if someone can say something about what comes to mind is that, there's no menopause in men. Or there's no woman.
We know the agree somewhere.
Okay, right. But it doesn't remove the fact that fertility may decline, as the man ages too. Yeah, the quality of sperm can also reduce as one ages. Yeah, especially once one is getting to 40 years and above. Yes, but an elderly man can still father a child. Yeah.
Interesting. Does anyone want to add to that?
Yes.
Okay,
so,
please.
Let me just add that, just like you said, the quality of sperm and the risk of having children with some deformities, some genetic abnormalities, chromosomal abnormalities, increases with the age of the father. So I think they are ever fertile, in my opinion. An 80-year-old man can still, but what will be the quality of that baby?
You know what I find interesting? I've always found men actually go through a sort of menopause that we call andropause. And I think men have I think men have really gotten comfortable with the idea that they think they're entirely fertile. I don't know if anybody has read The Secret Lives of Baba Segi's Wives. If you haven't, please read that book. And that's all I'll say about that.
All right, thank you for attempting to balance the equation. Anyway, all right, so let's talk about couples, intending couples. One is thinking of taking a wife or a husband. What are the key tests that you recommend that they should take, sir? Questions for you.
Okay. I think I've been asked this question. I was asked a week ago about the investigations or tests to be done before they tie the knot. Looking at it, I know churches do hemoglobin genotype, infection tests, and all that. But it's difficult to do further tests. Will you ask the guy to go and do semen analysis?
So if you recommend, we will, actually. Just
So
tell
how
us
will
what
he
to
do it? Will the sister help him? How will he do it? How will he get the semen out? So those are the concerns.
Except you're encouraging him to masturbate.
To masturbate. So,
Okay. It's a very, very difficult question to answer, but it's okay.
then, just like I said, the way I answered it on that day was, I think it should be more of openness. It depends on where we are. It should be openness. And then maybe they should also see a doctor, maybe a family physician, before going ahead, after doing all those tests. He or she will be able to ask some questions. Especially ED, erectile dysfunction. It's not impossible that a guy cannot even, do you understand? And then it is when the pastor has said, what God has joined together, let no man put asunder. And then they get to him, sister is saying, we must put asunder to this one.
Okay.
So the tests are actually not the tests that can be done easily.
So while you build on that, right, that question, I want us to also stay on erectile dysfunction and address what actually causes erectile dysfunction. But also, there's a question here that says, what causes sudden loss of erection during intercourse, and what is the solution?
I was going to build on the conversation he's had. And I understand why a lot of people had that, agitated response, because I see up to 10% of couples who are struggling to conceive, and they're coming in, and it's because the man has erectile dysfunction. He said something that is very critical that I wanted to emphasize on. Openness is so important. It's unlikely that a man who has erectile dysfunction doesn't know he has erectile dysfunction. You don't need to do a test to be told you have it. In fact, there was a couple that came into my office. The woman had never had sexual intercourse. So she had no idea what should be happening. And here's this young man, he had been deceiving her. Pretending. She didn't even know what penetration. I find that very hard. But she had no idea. And they'd gone on 2 years in their marriage. They'd never had penetrative sexual intercourse. And the man didn't know. And so they came in because of infertility. And the woman would say, hey, am I the cause? And I was looking at this man like this. So that openness during dating is so critical. And erectile dysfunction can be caused by a lot of things. Sometimes medication, and Dr. Alao had a slide on that, talked about, different medications, anabolic steroids and things like that. So the conversation, and what we don't do a lot of in this country that I'm encouraging people to do, have a family physician, have somebody that is responsible for your health, that can tell you, that follow the history of your health, and then when something is out of sync, it's easier for the person to pick it up. So your first point of call will be to your family physician to see you, evaluate you, and then take it on from there.
Ladies and gentlemen, take him to the family physician. Thank you very much. Okay, so more questions for you, sir, related to this. I'm just going to reiterate the question. What causes sudden loss of erection during intercourse, and what can be the solution?
just on a lighter note, maybe the man's bank account is down. Sincerely. Now,
do you mean to say that the bank balance is directly proportional to...
not unlikely.
But
just like we said, the importance of having a physician, sometimes we also need to be tutored, sincerely. Women have come to ask me before that, why is it that it doesn't stay long and all that? And I would have to explain, okay, when you're having intercourse and you take your mind off, you don't know what is going on in the mind of the man. You take your mind off what is going on. There's no how. It will go down. And it's also a system by which you want to use it to also extend you understand? You say it happens, it comes. I hope there's no underage. If you're saying you don't want it to happen quickly, is what you would be advised to do. Just take your mind off what you're doing, and then, it's innervation, the nerves the whole thing will go down, then you pick up again. You understand? But in this situation, most likely, it's not that. Most likely. Because if the woman is complaining, that means it goes down, and then to come up again, it's an issue. That's why she's complaining. I think it's a form of erectile dysfunction. It is. So some medications, just like we've said, antihypertensives, anti-diabetic agents, those things can cause, especially aldomate, can affect the erection. And then the disease itself could also, hypertension, diabetes, they could also cause dysfunction.
Thank you very much. Family physician, please add to it.
Just to mention a few things. Yeah, we've mentioned some of the causes of erectile dysfunction. We've mentioned something psychological causes, just like in the case of the bank account, or maybe the desire for the woman is no longer there. We've mentioned some medical causes, hypertension, diabetes, but there are some other lifestyle choices too. Smoking, substance use, alcohol, all those things have a way of affecting, erection. Previous surgeries, there are a long list of things that can possibly affect erectile erection in men.
But there's definitely something that can be done to address this,
Definitely,
right?
yeah.
Okay,
so you just need
fantastic.
to identify what the cause is.
Okay, so we need to see the family physician, understand what the cause is, and then address it. But please, one of the first things you need to do, women, is send money into his account. Let's rule out the bank account issue. Then we can move to the next item.
That's very important.
All right. So moving on, a child has had pain in their testes, and even 1 year after varicocele surgery, the pain still persists. What can they do?
They'll need to go back to the doctor. Sorry. So they'll need to go back to the doctor for re-evaluation. The child may need to see the urologist, the pediatrician again. Yes, just to be sure that there's no torsion, like in the process of having the surgery, something else didn't happen. Yes.
Okay. Would you like to take the question on secondary infertility? There's some question around that, and what exactly can be done regarding secondary infertility?
Okay, so secondary infertility, like was earlier defined, is the difficulty in achieving pregnancy again after being able to achieve conception before. And the different causes, it can be just like the scenario that was painted earlier, a no partner. So it may be you need to be sure that it's not from the other person. And then what is the age? The same questions you would answer for primary infertility, you would answer for secondary infertility.
Okay, fantastic. So please see your physician as well. Look through, discuss these issues with them and let them walk you through so that you're able to identify what the key challenge is, right? Okay. 3 failed IVF cycles. even after a successful hysteroscopy, I hope I pronounce it well, okay, that one, yes. And all that treatment, yet no conception. I mean, this is a pretty sad case because this person has highlighted that such situations have led them to a divorce and even a remarriage, and still nothing. What can be the problem and what can we do to address this?
Obviously, you will agree with me that it's not a question that I can answer here or that can be answered there. It's usually something that is saddening, and even to the doctor, to the managing physician. So the first thing is we need to see the clients. Well, it's not impossible. I've seen someone who has done IVF 20 times, failed, more than 20 times. She has gone all over the world to do IVF. And at last, she has a son now. So we need to sit her down and identify the cause. Sincerely, we need to identify the cause. Where I don't want to say that she didn't go to good clinic. Even the best centers, this can happen. You understand? So if we're sure that she's been well managed, we now need to look at a lot of factors could be responsible. One, we want to, for conception to take place, whether IVF or at home, you must have good embryos, and then the womb. It's not only let me just say the woman. Now, in case of the woman, or talking about the woman, you want to look at the womb. She mentioned hysteroscopy. That's one of the investigations that can be done to check the cavity, to be sure that the womb the lining is good. But we have other things. There could be autoimmune disorders that would affect implantation. So those are other things that can be looked into. And then demand too. Are we sure? What's the quality of those embryos? Sometimes they may look good because you've seen cases whereby you have fantastic, when you look at them physically, they are good. But genetically, they may not be okay. So those are things that we need to investigate and be sure that we are good.
If the problem is genetic, by the way, is that something that can be assessed in Nigeria? And
Yes.
Okay. So we can look at examinations that may not already have been done. Yeah.
I also want to then add the reality. Not everybody will be able to get pregnant, and it's important for us to say that. And that's why surrogacy is an option. That's why adoption is also an option. It won't be for everybody. And as I was listening to you about this particular woman, I want to give women the liberty to know when to say, I'm going to stop. I'm going to stop pushing my body. It's not easy to do 10 IVFs. Also remember that with each cycle you do, you're putting your body through something. We sometimes forget that. And I'm happy we're in church today. And Dr. Lagunje and Dr. Alao have emphasized faith and medicine work hand in hand. We're Christians. We will pray about it. God will give us peace that at some point you will know, live well enough alone for now, and turn to Jesus to tell us what next to do. It is important as women, don't keep pushing your body till the point of no return, because guess what? There could be a point of no return. People have lost their lives in the bid of trying to get pregnant. I just thought it's important that I put that in there.
Thank you very much. This question comes up every now and again, but I would ask it today. Hopefully we can get the medical perspective from faith-based people, right? Is IVF possible for mature singles? Is it restricted to married couples? What then is the hope for unmarried women in this conversation? Sir?
Absolutely. Now, let me come to the ethical aspects. We are in church, but I won't look at the... Unfortunately, we have ethical guidelines in fortunately, we have ethical guidelines in Lagos State that governs IVF. Single women are allowed, and in some part of the world too, are allowed to have IVF done without a partner. But single men, no, they are not allowed. Because every child, Every child has the right to have a mother. Anybody can be a father. Even, yeah. So even for adoption, she just said it now that adoption, women are allowed to adopt, but men are not allowed. You can't go as a single man to adopt a child. So women, for IVF, the same thing happens. I've turned down so many cases of men coming in to say, oh, I'm single. I say, go and get a wife. At least have a partner. But women can come in, they are mothers. That child needs a mother. So the other way too, women have an age whereby we say no. In Lagos, it is 55 years as of today. We say no, we cannot, because, and the man can be 80 years old. So it's not like it is one-sided. That's a part of the one for the women. At age 55, we are not allowed to actually conduct IVF on the woman. But the man can be 90 because we want the child to have a mother that is still able to take care of the child that still has energy. I love what Dr. Odesha, and it gave me in fact, it changed my perspective about, we should not just, I must have a child. Thank you, Dr. Odesha.
Okay. Still on IVF, just before you put off the mic, still on IVF. We're going to go around, definitely, and I'll go back and forth. So please don't get bored. And the questions will come back to you. But still on IVF. The question is, are there spiritual concerns with using donor eggs from an unknown woman? They don't understand her lineage. They don't know if there are witches there, right? And what measure do doctors take to screen and match these donors? Should we be concerned about spiritual issues? Have you heard about such before? Otherwise, what should we be concerned about?
It's a question I've been asked over and over again. But looking at it as a believer now, just like Dr. Desha said too, we can go to God and understand what exactly He wants you to do. But medically speaking, what I ask clients is, I've seen cases whereby it's the man, the woman does not mind. It's the man that will say, oh no, I can't go ahead if it is not my wife's eggs. And after 1 year or so, that man moves to another woman. That new woman, what investigations, or did you do genetic testing on that woman? Did you go to their village? Those days, in the olden days, maybe they were doing that. They would go to the lineage. They would say, what, did they have this in their family? But now we don't even do that again. Because some of those things are not actually genetic. If you want to do genetic testing, we can do genetic testing. If you want us to do genetic testing on the donor before using that, we can. It's possible. We'll just analyze. But at the same time, as we are doing that analysis, we should analyze the man's own too. So we are sure there won't be issues. If she is a carrier of an ailment, the man does not also have. But before, your husband and wife, we don't do that. So why do you want to now, because we now say donor eggs, you are now asking questions that girl in their family, do they have witches, or are they mad in their family and all that? Unfortunately, in this part of the world, we don't keep, anything the lady tells us is what we will take. There's no way we can investigate. We don't have record of families, the father, the mother, so it's not possible. But what you will just do is to believe God. If this is what God wants you to do, it will work. We have seen cases of couples who have used donor eggs, and they are fine. Excellent.
Thank you very much for that. Okay.
The additional balance I wanted to put in there, it's not an unfair question to ask, because the reality is you don't know where the donor is coming from. And so expectedly, there are some questions or evaluations you need to, because there's medical history. Now, the difference between when it's your own egg is, even if something shows up later in life, you can ask one grandfather or one auntie, do you know who was there a family member like that? That element is taken off. And so the balance is the faith and the medicine. Let the medicine do as much evaluation as they can. And then you go on your knees in prayer. And because this thing is about grace too as well. Because there are families where it is your egg and the child is problematic throughout the child's life. That you're even, and I'm serious, that at times I even say, which kind of child did God give me like this? And it's your egg. You don't have control of that. And that's why the balance of faith and medicine comes. Let medicine do the evaluation that they can do. Then you're a praying child now. Go on your knees and pray. Looking for that donor ego, let the lines be matched onto me for pleasant places, so that the egg that comes before you is the one that is chosen for you.
Thank you so much. I mean, I don't think we could have found a better topic for today's event. Thank you all so much, and even better speakers or experts than we have on this podium. Thank you so much. Thank you. To the pediatrician, a child is obese with dark skin on certain areas, like on the neck, and this child also have irregular periods. Do the parents need to worry?
Oh yes, they do, because that's already signs. Yes, telltale signs of PMOS. So there has to be caution, and just to reemphasize the need for good nutrition. There are a lot of junks now, and it seems as if our children are now our bosses. They are our ogas. They're the ones that tell us what to do and how to train them. So we may need to get the steerings back from them and redirect them, particularly because they come into the clinic and the mother is helpless. I'm like, okay, 12-year-old, 100 or over 100 kilos. Oh, yes. And then 15 over 100 kilos, no periods or irregular periods once in 4 months. And I'm like, okay, the first thing, you need to go to the dietitian to map out a better nutrition plan and then exercise. Oh, doctor, she will not answer me. She will not. Yeah. So it seems we underestimate the future implications of some of these things from the outset. And it is the earlier, the better, really. So that's...
Thank you very much for that. Mothers, please, can you activate your African motherhood? Research statistics exist now. Use it. Anyway, thank you for that response. But I want to, reiterate one of the points in that question. She said dark patches on the neck. People in Nigeria believe that, you can give birth and you have birth marks. Is that also an indication, or are there marks that we should look out for?
Okay, so the dark patches we may need to reevaluate. I would have assumed that may be like acne, and part of some of the features of PMOS would be hirsutism. So having hair pattern, male hair pattern in females. So hair along the chin, like having beards and things like that. So it may just be a precursor for that. Like something that is going to happen. So, the dark patch, I'm not sure exactly what the dark patch could mean, but we may need to bear that in mind. Yes.
All right, fantastic. If you have questions here in the auditorium, please feel free to write them down, and you can even pass it to the ushers. Okay, please, let's do that immediately. Let's do that right away if you have questions. Another question, this question is for the family physician. Can having HIV impede one from having children, especially for a woman who's had children before now? Does having HIV now, can it prevent her from being able to
Do you mean
pregnant?
the man or the woman?
I think you can respond to it from both perspectives.
Okay. HIV does not directly impede fertility. That one is HIV positive does not directly impede fertility, both in the man and the woman. And that's why HIV parents can give birth to children, but it can also, the transmission can be prevented in the child though. I think that answers the part of the HIV regarding fertility. I don't know, what's the other question?
No, they've had children before. Can it impede? That's just the question.
Okay,
and
well, like you said, HIV does not directly impede fertility. There may be other factors why they are not having where they are now having secondary infertility. They get a long list of other things. Yeah.
Okay. All right. Fantastic.
So if I could just add my thoughts on that as well, is that there's HIV and there's AIDS. HIV is having the virus. AIDS is when the virus has permeated your entire system to now cause clinical symptoms in different organ systems. So HIV in itself, can't impede fertility, except the person's virus load is high enough and you're not able to have sexual intercourse because you don't want to infect your partner. Then, of course, if you're not having sexual intercourse, and of course, there are ways around it, and that's where Dr. Bamidele and his team is readily available, and other IVF specialists. So if you have HIV and your levels are high, then, of course, assisted reproduction is an option where they can then retrieve to avoid sexual intercourse. But then if you then have AIDS defining illnesses, then that can impact on erectile dysfunction and all of those things.
Yes, that's true.
Okay, thank you very much. If you do have questions and you want to ask directly, feel free to put up your hands at this point if you've not written down. Yeah? Okay, so that's one. Is there any other person who wants to ask a question? Two. We can only take one more. Any other person? Three. Please, can you help pass a mic? Thank you very, very much. While we're trying to get the mic across, let me quickly take this question. Someone in their mid-40s who have been trying to have kids for about 5 years. They have fibroids. They've done all sorts of investigations and treatments. They're looking out for options. And they're also asking, is natural conception still possible? Okay, happy to pass it over to you.
Okay, so for them, I think she can still achieve conception, especially at home. Just like Dr. Desha said when she was giving us the lecture, we need to know where exactly the fibroid is. Is it in a position whereby it could impede implantation and conception? So she needs to be evaluated at 40, mid-40. It's going to be a lot difficult, but it's still possible. It's still possible. If they now find it after evaluation, if it is still difficult, there's nothing disturbing the fibroid, is not, because she just mentioned fibroid. Maybe she did an ultrasound scan and then they said there's a fibroid and all that, and she felt that could be the cause. That may not be the cause. So they need to be evaluated, and then, if need be, we're available, would see what can be done. Okay. But at that time, it's going to be IVF.
Oh, you have a question for you? Who take it?
So I wanted to ask you from your own experience. So from a gynecologist's point of view, we say 45 onwards, your egg quality and egg count is not practicable. And so when I see patients, we do AMH. The AMH is low or no normal. From your experience and patients in that age category, how many of them have you successfully, ratio-wise or probability-wise, how many of them have you really been able to use their eggs to be able to achieve successful conception?
While you're answering that question, because it relates very close to the question here, which is, what is the percentage success rates of this IVF SEF? You understand?
I think I will start with, with that.
All right.
Globally, the success rate of IVF is about 30-35%, sincerely. 30-35% is better than what happens at home. But some centers, we've been able to do above that, much above that, far above that, about 50%. First quarter, don't let me go to personal stuff now.
Okay.
We've been able to do close to between 50 and 60% in some cases. And, so many things will be considered when you're looking at it. We have, especially in this part of the world, just like this question, people who are 42, who are 45, I want to use my eggs. 50, I want to use my eggs. And then you listen to them. For them, it's a form of closure. Let me just see. I know it may not, but I know what God is saying. And then we go ahead. That will affect your success rate. But in our clinic, we can put them aside. Such people.
Categorize them, yeah.
Exactly. So outside that, above 50%.
But among that age group, what would you say is the success rate?
After 42, the chances are actually less than 1%. I've seen at 42. I've seen a woman using her eggs and achieving conception at 42. But after 42, 43 and above, I think between 1999 and 2020, I learned of one case. And I was also outside the country. I asked the same question that we've said after 42. I was asking them in that clinic. They started IVF long ago. They were able to count on one hand how many 42 and above they've been able to treat
So
successfully.
chances are slimmer, significantly slimmer. All right. I did ask for questions, and I do have a good number of questions here. So I'm going to crave the indulgence of our experts. You spent some good time with us, but it also means that the people in this room trust you and believe that you are answering their questions and can answer some more. So we might stretch this a bit more if you don't mind. If you do, please let me know. Otherwise, please relax. Drink a cup of water. Drink water, right? And then we'll quickly run through some of these questions. Here's what I'll do. We'll take one question from those in the room, and while we're trying to pass the mic to another person, I'll read from the questions that I have here. But please permit me to start with this question before we take yours. And this is for the pediatrician. We have a child here who has had acne since 4. They visited dermatologist, and those concerns still persist. And she started having this, from a very tender age. Obviously, 4 is also tender. Can this possibly affect her fertility? Is this an indication? Should the parents be considering the impact, or whether this is any indication of issues with her fertility?
Okay, so I would want to assume that this acne in coat is something we call atopic dermatitis, and it can be sometimes difficult to treat. It's just one of the symptoms or one of the features on the spectrum of allergies. So it has nothing to do with infertility. It has nothing to do with that.
Okay. Would you recommend they see a gynecologist? I mean, a pediatrician anyway? No?
They're already seen a dermatologist.
Yes.
Yes,
Okay,
so that's fine.
That's fine. All right. Thank you very much for that. Over to you, sir.
Hello? Okay. Thank you very much, everyone. You've been wonderful, our panels of experts. Thank you so much. It's A and B. Sorry, I just have to ask. One is a question, and of recent, we're hearing things like deodorants, hair cream, that affects, especially the ladies. It affects how their fertility, whether they can get pregnant in the future. But these are things that are used, everywhere. How you can't escape it. One cream, body cream, hair cream, deodorant, spray. How will they escape that? Because from stories we're hearing, these things are actually affecting the fertility of ladies. So that's the question. The other one is, you might not have an answer, but what would you say? Because there was a time when my wife was pregnant, we knew someone, and one of the things she just said is that she lost twins, and she did everything. And the thing that struck me, she said, but there was one mad woman that stayed in a gutter that gave birth. And you're saying have lifestyle choices, this. The mad woman is not doing all that, while the person that is doing all that still lost twins, and it really pained her. So I'm just trying to, what do you say to those kind of people when those things come up? Thank you.
All right, thank you for the questions. So for the first part of the question, we don't have data to really tell how much of all these cosmetics, affect fertility. But it's important to know that we have to be careful with things we buy to, use on our bodies. We have to verify the products that we use. whether on our bodies or even the things we eat. One of the things I mentioned in my slide is, exposure to, environmental toxins. I mentioned pesticides, herbicides. That's for people who are into agriculture, most likely. Even people who work in some industries, exposure to some heavy metals. And some of these products too can have some of these things in them. They may not really say these things obviously in those products, but we have to, be very vigilant and be careful with these things. We should go for verified products if we're going to, sometimes you can ask your doctors like, okay, or bring the product to your doctor, let you and the doctor go through the contents of, what you're using and be sure they're not harmful to your bodies. Not just for fertility, but for, other things. The second question about, okay, a mad woman giving birth to babies while someone who is seems to be normal is not, is having difficulty to get pregnant. So the fertility is a function of biology, really. It has nothing. It has very little to do with mental states. It's about the biological function of the body. Yeah. So someone must have gotten her pregnant, though. Yeah. So yeah, it's a yeah. You may say that okay, she gets to eat dirty things most of the time. But what about the person that is not doing all that, but is also engaging in some lifestyle activities that, harm the body? What's it called? Using some very harmful products. A mad woman would likely not go for, things that would be harmful to the body. It's just for her to eat certain things. Fine, may not, get, she may not get
Hygiene?
Good hygiene and all that. She may not have sexually transmitted infections because she's not taking care of her body. Most of the problem will be on the outside of the body. I don't know if you get that. But again, it also all boils down to divine, God has a way of doing his own things. Yeah. So, so I was just trying to explain some things in the medical way. But again, at the end of the day, we are all creatures of God.
All right.
Yeah.
Thank you very
Thank
much. So question for you now. I know we've talked about women who are above 40s, and I'll talk about that a bit more, but what can a woman do who has fibroid inside her womb and has intramural fibroid, actually? What can she do?
So to answer simply, if you have fibroids that are impacting on fertility, get it removed. It's a simple answer because, going through a surgery is a big deal. And so let's not underplay that as well. And so it's not something to just walk into with say, I'm just going in for a surgery. But I think this is where, seeing your doctor and being practical with yourself as well comes into play. Because I've had, people come to me 3 years ago, they had fibroids. They were more manageable at the time. But, God forbid, it's not my portion to do surgery. They run away. But guess what? They come back. Because one of our analogies in medicine is that ignorance is not bliss. Simply wishing the problem away doesn't take the problem away. They come back 3 years later, the fibroids are much bigger, it's more complicated. And guess what? That surgery you ran away from 3 years ago, you're still going to do it. So if you have intramural fibroids, like I said earlier, and what all of us have been reiterating here is to evaluate and determine, does it need to be taken out? Once that determination has been established, then it's got to be taken out.
Question, yeah. What's the difference between clogged blood and fibroid? Does clogged blood affect menstruation?
clotted. Oh, okay. So what's it? They're not
Okay,
the same
they
thing.
meant blood clots. Oh, I see.
Blood.
Oh.
Yeah, they're not the same
Solid
thing.
blood.
So like we've established earlier, one of the common symptoms of fibroids is heavy menstrual bleeding. And usually when you're bleeding that heavily, the blood then tends to clot. And so if you're having heavy menstrual bleeding, it's not normal. It needs to be addressed. Now, the question is, what is causing the heavy menstrual bleeding? If it is determined that it is the fibroids, and so sometimes I tell patients, it's not even about fertility. If you have fibroids that is causing you to bleed that significantly, whether you're interested in having children or not, that fibroids needs to be addressed. And so there's a difference, is that if you have fibroids, it can cause you to have blood clots. And if that is happening and it's that significant, you can lose so much blood that you become severely anemic. And remember that the role of blood for us is to help us with our daily functioning, because blood carries oxygen to all your vital organs for them to function. So if you don't have enough blood, you're not having oxygen to help your vital organs function, and that can be detrimental to your health.
All right. So consider your overall health and do something about it. Now to the second question. Do we have Mike? Yeah, please go ahead.
So I'll first of all say thank you to our panelists. Thank you so much. My question is this. If in a case of endometriosis or diffuse adenomyosis, and from my knowledge of it, in some cases they would suggest that you can use medication. In some cases they would say surgery. What if the person doesn't want to go through the route of surgery? When does it get so bad that you can no longer maintain with medication and you have to do the surgery? Thank you.
So to that, let me just put a bit of context to what adenomyosis and endometriosis is. So the lining of the womb that sheds every month is called the endometrial lining. That lining is meant to be only within the lining of the womb, so that every month when the egg is released and 14 days after, when there's no pregnancy, it can shed off as menstruation. Now, sometimes what happens is that lining of the womb is found in other areas beyond just the lining of the womb. So one of the commoner areas it can be is within the ovaries. It can be within the pelvic cavity itself. It can be in the eye. It can be in the brain. It can be in the lungs. I have managed patients who've had endometriosis in the brain, had it in the lungs, and we've had to go in surgically. So imagine that scenario where the lining of the womb that is supposed to shed every month. So it will shed. So wherever it finds itself, it will shed. So what would that mean? You will bleed in your brain. You will bleed in your lungs. You will bleed in wherever the lining of the... So that's endometriosis. In those other sites, it's not as common. The commonest site is ovary and within the pelvic cavity, and that comes with symptoms. And you can imagine, normally when within the lining of the womb, you bleed and you bleed out. Do you understand? But now you're bleeding in closed cavities. Of course, it will cause symptoms. Now, the sad thing about science right now is there's no cure for endometriosis. We keep managing it. It can be quite disheartening and stressful, particularly for people who live with it. Now, what is adenomyosis? Adenomyosis is that lining of the womb that is... Now, the womb has 3 layers. The outer layer, the middle layer that someone was talking about, intramuscular, and the inner layer. The inner layer is where the lining of the womb is meant to be. Maintain your lane. Now, if that lining of the womb is within the muscle area, that's what we call adenomyosis. Of course, that also comes with symptoms, because now you're bleeding within the muscle of your uterus when you're bleeding every month. Now, one of the basic principles of medicine is there's never one absolute way to do anything. And with patient autonomy now, the patient gets to decide what they want to do for their bodies, because it is your body. As much as we're medical professionals and we have the knowledge as to what is likely best to be done, our job is to counsel you on what the best option is, the pros, the benefits, and what the alternatives are. Your job is, what am I best comfortable to doing? With endometriosis, it's tricky, and usually the pattern of endometriosis management is you start out with something, use it for a couple of years, it stops working, you switch plan. Surgery is not always the answer for everybody. If we're going in for surgery for a patient with endometriosis, it's very clearly defined. And in fact, surgery is not our first option because of the nature. And so if we're going in for surgery for endometriosis, it's very specific. Adenomyosis is a bit different because adenomyosis, if it's localized, it's easier because the purpose of surgery is to address something. And so if you can't clearly define what you're going to address, then don't go in for surgery. We use medications. Unfortunately, it's a waxing and waning thing with endometriosis. Sometimes you get good seasons, sometimes you get really difficult seasons, and we keep managing like that until you get into menopause. Sometimes the bigger issue with endometriosis is over time you bleed into the pelvic cavity, it causes and affects other organs. So it's not even just about, it's a tricky one, and it has to be individualized. I hope I've been able to kind of, yeah.
Yes, I mean, you've educated all of us at the end of the day, so definitely I'm sure you got something there. All right, so we have a number of women-related questions, but we do have, opportunities to meet with, have consultations outside, and so I would encourage us to take advantage of that. I'm just going to take quickly these questions that are more related to men. It says, what can be done to increase sperm motility? And if you've been trying for years and all the tests indicates everything is fine, what can you do? Can I direct that to the family physician? And then the final question I'll take from this list is, as a new dad, this dad wants to understand the negative effects of pressing a female genitals of a baby with hot water, not warm water, hot water. Can it affect their fertility in the long run? I'm sure that's a cultural thing. Yeah, so starting with the first question.
Okay. Thank you. For sperm motility. Okay, from the family physician's perspective.
Sorry, can I ask that we answer the question in just 2 minutes
okay,
briefly as possible?
First thing, or the most important thing is lifestyle changes. Family physicians are very big on, emphasizing on lifestyle choices because he has a way of affecting her health a lot. So lifestyle changes, lifestyle choices are very important. And secondly, once it's discovered that it's poor sperm motility, the causes need to be, determined. So it's also important that you see the doctor, get assessed, then get treatment depending on what the cause is. Yeah, sure, definitely.
Thank you. All right.
Because they have a way of picking the right ones.
Exactly. So maybe that's something to consider. All right.
So as regards the hot water, I'm not sure it has anything to do with fertility, but more of the safety of the baby. So let's be sure that we're not going to do something that will cause burn injury. I know that it is cultural, maybe grandma doing something that she did for the forefathers that worked, so but let's just be sure that we're playing safe with the baby.
All right, fantastic. I'll just summarize it as stop it. Please stop it. Don't do it again, please, for our sake. Thank you very much. I know you're being diplomatic. Let me help you. All right, so we have one more question in the audience. We'll take that quickly. Please, can we have a mic passed across to him? Or provided to him then? So we have, that's number 3 there, yeah?
Thank you so much. Sorry. Thank you so much to the panelists. I just have to ask this question. I'll try and make it brief. I have a friend. She's married, and she had a first child through some pains. She has fibroid. Now, her sister went in for fibroid operation and died. So she's having the phobia of not wanting to do an operation. But she's really, during a period, she's highly affected. She's in pain. She lost blood to a point where you could see physically that she's emaciating. But she doesn't want to do operation. So now, how do you convince her? Because when I was coming, I told her to listen to this program. So how do you convince her to do an operation? Because the fear, the fear is a phobia of what happened to her sister.
This is how I help people make decisions, benefits versus risks. Everything has a potential for risk. And so when you're making a decision, the question to ask yourself is, does the benefit outweigh the risk? When the benefit outweighs the risk, then you give yourself the opportunity to go ahead in spite of the risk. The other question to then also determine is, what is the probability of this risk happening? You know how some risk is 1 in 1 million, while some are, 5 in 10. But the baseline is the benefits versus the risk. The second thing I'll tell your friend to do is, it's a real fear and it's not something that can just magically go away. But what I would recommend you do is, please go to a center, a hospital that has a reputation for being good at what they do. Fortunately for us in Nigeria, fibroids is common in our midst. The average gynecologist in Nigeria knows how to handle fibroids. The question to then ask about her sister's case, howbeit very unfortunate, was where did she do the surgery? Who did the surgery? What were the circumstances? Maybe that would help her. So if you're going to a good center, and there are 1,000 good centers in Lagos that can do a good fibroid surgery, the question you should be asking in the hospital, who is your gynecologist? What is your setup to be able to do a safe surgery for me? Do you have blood setup? Do you know all those? Do you have an ICU? Because again, the risks are there. And so it's not to pretend like the risks are not there. They are there, but is that setup equipped to be able to manage that risk? And again, as the primary question, who is the gynecologist? Is it a gynecologist? A certified, in Nigeria, as with other professions, things happen. People claim to do or can't do what they can't do. But then to ask ourselves, the benefit of the surgery versus the risk, and this bleeding every month, she can die from losing blood consistently that way, and that is a greater risk than if you go to a good hospital with a good surgeon to do the surgery.
All right, thank you so very much. Thank you very much. Do our panelists deserve a round of applause at this point? Yeah, thank you. Thank you. Thank you. It's really been a very interesting, insightful time. Thank you so much for making the time, for being here today. Allow me to apologize for those who sent their questions here and were unable to take them. You agree with me that they spent quite an amount of time, even beyond the scheduled time. And we also need to show respect for their time and the other activities they have to carry out. So thank you very much. This brings us to the end of the session. We'll be taking quick pictures, quick photograph. May I ask that the pastorate, the head of the medical team, join us in taking the photo.
Thank you so much. You can have your seat. Where do I start? First, I want to thank you all. Dr. Orelu Alagunju. Right from, I just posted it on the HOD's, the global medical group, and said I needed a pediatrician. And immediately, without asking questions, you see, you people I love Dotisi and Isolo. Immediately she responded and, she accepted our invite. Thank you so much. Dr. Alao, I don't know how I'll thank you, but I will say thank you. Dr. Alao has a personal engagement today, but because you people in TCN Isolo and even online, you people are loved, he shelved his own personal engagement just to be here. Please, let's appreciate Dr. Alao. God bless you. Dr. Adesumbo Odesheye, you may not know the relationship between the two of us. She was my roommate in medical school. So she came here today to harass me. And every time she just keeps saying, it's because it's you. It's because of you. I mean, if those that were on the webinar knew that she was in the office and they were saying, doctor, she was like, give me 5 minutes. Give me 5 minutes. So she gave us her time during the webinar, and she's also here today, even fully with her team. Dr. Adesumbo, we appreciate you. Thank you. And last but not the least, Dr. Bamidele Babatunde. He is my mentor. Even in the midst of all this planning, he was asking me, so what's next for you? What are you doing? And Dr. Bamidele, I've worked with him for years, and he has been an inspiration to me. And he's also a pastor, so you would have detected it from the way he spoke. Dr. Bamidele, thank you so much for coming. God bless you. We want to appreciate all our specialists for the time they've spent here. And especially we want to say thank you to CAF Maternity and Laboratory Center, as well as Havila Fertility Clinic for giving us concessionary prices for our treatment. Please, let's give them a round of applause. So please, those of you that are here, it's like you have expo. As you are coming out, just go to their stands, write your name down. We are not even asking you to make payment or anything. Write your name down, register your interest. Don't let all this information and freebie go to waste. Why? Because the offer is valid for just the next 3 months. We don't want to, leave it open-ended and there's a lot of confusion, so that there is, they can pay particular attention knowing that you are coming from TCN Isolo. And remember that the code word is TCN Isolo anytime you go to approach the clinics. Also, I want to appreciate every volunteer, every worker in TCN Isolo. Give yourselves a round of applause. Everybody has been so fantastic, going up and down the place, making sure everything is working well. You are highly appreciated. Finally, I want to appreciate the medical team. This is an idea that has been birthed over the last 3 years. And we've just been thinking about it, how are we going to do it? And finally, it has come. I know I send messages to you at 2 a.m. in the morning. Somebody like our collaterals flyer designer, he will avoid me for like the next 1 month. I accept. But thank you so much, everyone. And on behalf of TCN Isolo, we would like to declare this seminar closed. God bless you on your journey as you go home. We expect miracles, signs, and wonders. God bless you all. Bye.